Today, I am delighted to be joined by Robert Lederman, who is a board-certified neurodevelopmental optometrist who's seen over 18,600 patients, he tells me. Robert, thank you very much for joining us today.
It's a real pleasure. Thank you for having me.
Do you want to just
Really.
tell us a little bit more about your experience, your practice, and the type of patients you see and help?
Sure. I work in private practice. I've been in private practice for over 35 years, graduate of City University. And I see people of all ranges, obviously from children through adults. The oldest patient I've actually seen and worked with was 101 years old,
Mm.
which is a story in itself. Um, People are coming, it's a referral-based practice. I've never advertised. I've lectured a lot, done what I can to help people understand that vision is more than just seeing small things from far away, what we call 6/6. I think everyone sort of understands that, but it's not something we talk about so often, and certainly the public aren't so aware. So I've really done a lot over the last 35 years to try and raise awareness amongst professional groups, including ophthalmologists, neurologists, psychologists, occupational therapists, teachers, of course. And as such, and as a result of, thank God, the success we have and the outcomes that come about from changing the way people gather information, thank God the office is really very busy. I probably see about 35 to 40 new patients per month. Um, and I have a team and we improve people's oculomotor vision skills.
Mm.
And I really try to. I've lectured a lot and the outcomes have been pretty remarkable. So just
Well, that's
trying to do what I can all round.
Yeah, we're doing great work. We can talk about lots of topics. We have lots of things which we're both interested in come at from a different angle. But I think today we're going to focus on one topic which I know is one of your favorite topics, and that is convergence. Let's just break it down really into a few basic things. So we'll talk about what convergence is, and then we'll talk about ways to assess it. And then maybe we'll talk about some disorders or problems of convergence, things that you see in your practice where you can help people with issues about convergence. Does that sound fine?
It sounds good. Yes. Yeah, absolutely.
Tell us right from the basics, what is convergence? What roles does it play in life?
Okay, so let's break this down, as you said. I think the first question when we think about convergence, which I'm sure most of the people watching here understand, that convergence would be, let's call it simultaneous. It's the expression of our attempt to simultaneously adduct our two eyes. Um, I think that's a good definition of what we're doing motorically. And then the purpose of
Did you
convergence.
just say motorically?
Yes.
Okay, that's a new word for me. Motorically. I like that one. Okay, I'm going to start using that one. Did you just make that
Well,
up, or is it a real word?
there's all that motor functioning going on. Richard Bruenach has written some wonderful papers on intermittent exotropia, looking at the whole proprioceptive feedback coming from extraocular muscles and the lack of myotendinous cylinders, those cells which live at the junction between the muscle and the tendon. And he's found in his research there's actually a lack of those myotendinous cylinders, which affects the proprioceptive feedbacks. There, I'm just saying that to understand there's a whole motor story going on in the visual system. And, people talk about fine motor. Well, the finest motor of all the fine motor is in the visual system.
Hmm.
Nadeem, stop me if I'm going off on a tangent. So, because
That's
we
all right.
can
It's all right.
hours and hours and hours about all of
So
this.
we got a basic definition
But I
of.
want to say I've said about the simultaneous adduction.
Hmm.
Remember that our eyes are not connected in any way, so it's a skill. It's an oculomotor skill. It's something we learn to do. We
Hmm.
learn to converge. Now, the other point is, what's the purpose of it? And Skeffington, who is really the father of behavioral developmental optometry, who started teaching in the 1920s, said that convergence is the overt of localization. I'll
Hmm.
say that again. Convergence is the overt of localization. And that's based on the premise from and which has been substantiated by Melvin Goodale from Waterloo University, who's written a book called Vision for Action, which is a wonderful book. It's really the purpose of convergence at the most fundamental level is to enable me to understand where the object of interest is if I want to perform a motor response on it.
Hmm. But
And why is that? That's very important for us to realize because when we actually want to reach out to grab something, that's a very high stimulus for convergence. And I'm sure, Nadine, why you got me here to talk about convergence is also because we're sort of thinking about reading, convergence for reading. I
mm,
know that someone come in and asked me about convergence for hunting, but convergence for reading. Now, when you think about the stimulus, we're not reaching out and touching anything. It doesn't really matter where the word is on the Z-axis. So what I want to say is that different activities, and I could show you videos which actually demonstrate that, different activities have different stimuli level
mm,
for the convergence response,
mm, mm,
which of course brings us to the question of why we're testing convergence. And we're testing convergence to see if someone can converge sufficiently and with enough ease to meet the visual demands, the visual vergent demands of that task,
mm,
which are in grabbing something, it's to avoid the diplopia, so I know where the image, it's to know, in grabbing something, it's to know where the image is.
mm,
But in reading,
mm,
it's really to avoid diplopia, which is
mm,
a much harder, taller order
mm,
than normal convergence. So,
mm. Okay, so
when
just
you're getting
couple of
yeah,
questions come to mind. So, obviously, for any distance which is shorter than infinity, there's going to be a slight degree of in-turn of the eyes. But at what distance does convergence as a mechanism kick in? Is it like a meter? Is it like 2 meters? You said about the range of touching things. Where would you say convergence begins to kick in?
well, if we take that definition that it's simultaneous adduction of the two eyes, then you're doing that anything closer than, let's say 6 meters infinity, you're starting to do that.
Mm,
Your eyes are no longer parallel. I mean, they're not even parallel really when you look infinity, but you
yeah.
are having to organize that, and you're going to be using your medial rectus muscles to
But do you
perform
think there's
that
something? Yeah,
doing.
but what I'm getting at is what I wonder is it does, obviously there's bilateral adduction of the eyes for anything less than infinity. But is there some special mechanism that kicks in into this kind of near world, the world where we have to go like more than 10 degrees or 15 degrees? Is that something special or is it just a sliding scale right to infinity?
That's a really good question. And I think it is probably a sliding scale, although it appears to be more challenging the closer it gets.
Mhm,
Yeah.
mhm,
So you're really going to get someone saying here's their point of comfort or discomfort. Something which interests me is actually to find out when the patient actually feels uncomfortable, even if though they can converge all the way up
mhm,
there.
mhm.
Um,
And
so
and the other
yeah,
thing which I'm going to ask you a question. Uh,
please ask.
I do things like this. I'll hold a pen in front of my left eye, okay, and I will bring it in, and you can see my right eye hopefully will be turning in, but my left eye hasn't moved at all because it's directly in front of my left eye.
Correct.
So that doesn't fit our definition of convergence because this eye didn't adduct at all. It was completely straight. All that happened was the right eye progressively went in. So is our definition actually correct? And this is important when it comes to reading because, what your definition works if the thing is down the midline, but as soon as you're off the midline, there'll be times when it's one eye relative to the other, or one's doing more convergence than the other. Is that right?
That is 100% right. And it only goes to emphasize how challenging when something is not on that horopter, how it can be challenging, uh, more challenging to do an uneven convergence, if you want, on one side of the page. Then there's the middle, which is the ideal, and then there's the other side of the page. And I think typically we'd center ourselves so
Mm,
that as much as possible, the object we are responding to, attending to, is down the midline. That's called
mm,
centering. And we use our neck and our torso in order to try and do that. But you're right, we are exploring a larger area of space often, and that does lead to some asymmetrical innovation in order for us to maintain single vision in a certain area of space. Yes,
mm.
that is true what you're saying.
And you mentioned that quote about one of the benefits of convergence, or the prime benefit of convergence, is the overt of localization. So this finding where something is in the visual field, presumably relatively close. But what about stereopsis? Would you not say I mean, you could do that with one eye, right? You could localize with one eye in the XY axis, but it's the Z axis, which is so how does basically convergence is its real function actually to permit stereopsis?
I would yeah, I would say stereops is a higher order experience. Um, when you say stereopsis, do you mean is it the ability to look at random dot stereograms and
Yeah, I mean
to
that's a good question. Okay, so what
you
I
know,
mean by stereopsis, what I really mean is that pop-out feeling of depth that we experience. That's what I really mean by it, as opposed to stereoacuity, which is the ability to do, those type of tests.
well, Goodale did a lot of work. I don't know if you're so familiar with that one. His patient DF, who had brain damage, which did not allow her to understand orientation
Hmm.
in so if you gave her a slit at a certain orientation and asked her to line up her pencil with that slit, she couldn't do it. But if you gave her something to post
Hmm.
in the slit, she was lined up like anyone else, two-thirds of the movement inside. And this caused them to do a lot of work on the dorsal stream, right? There's a dorsal stream, which is what governs our motor response to space. And there's the ventral stream, which is more this experience, which leads into executive functioning and perception. And sometimes I think that what you're talking about, the stereo vision and things popping out for us, it's almost enjoying the aesthetics of the
Hmm.
result of being able to align our eyes, which what I want to talk about is when I think of it, I always think of the organism, as it were. Fred Brock spoke about that a lot, about the exotrope, esotrope, the organism. So there's the primitive brain, if you want. And it's when we talk about, when Skeffington is talking about convergence being the overt of localization, it's so that we can make a motor response to
Hmm.
it. It's not looking passively and understanding depth, which, as
Hmm.
you've written yourself, we can understand a lot of depth just even looking with monocular cues as well. So
Hmm.
that if you say, well, what's the main difference between perceiving the world monocularly and binocularly? It would be that the binocularity is the one which affords me the ability to put the stick in the straw that someone else is
Hmm.
holding.
Hmm.
Now, even if I looked at that stick in straw with one eye, I would still know there is a stick out there in space in front of me. But when I need to make a precise movement to it, I am unable to do that unless I have
Hmm.
the stereo vision.
Yeah,
Whether or not I can see 10 seconds or 40 seconds or 50 seconds, 100 seconds, that's something else. I think that's just I wouldn't say it's a curiosity, and it brings a lot of good clinical information about how retinal function is working, but it brings me less information about motor function. And I
Hmm.
think that's an important point. It means you can have good stereopsis, but lousy motor function in a dynamic sense as you're moving your eyes across the page.
So I think this is a really, really important topic for people in my world. So, myself, orthoptists, and people in Strab world, is that we do focus a lot on things like stereopsis, but we don't really do as much about binocular coordination during movement and things like that. So maybe we can talk a little bit more about that. Okay, so we've had a little discussion about the basics of convergence. How do you go about assessing it in the average patient? Obviously, there'll be battery of different things you do in more complex patients, but in the average patient.
Okay, so I'm going to say again, one of the important things for me is to try and understand what they're trying to do in their life
Hmm.
and make sure that I'm actually assessing whether they're meeting the visual demands of the task. I'll just give you a very simple example, which is relevant, of course. If someone is playing snooker, I need to know that. I need to know that his hobby is snooker because I'd like to know if when I'm testing his convergence, that I'm testing it in upper gaze. Right,
Mm.
so when he's looking down onto the table, he is using upper gaze. And if he had a V pattern exo, the high exo upper gaze and a regular exo and lower gaze, and I just check him in lower gaze, and he leaves my chair, who else, Nadine, is meant to evaluate how he's performing in his world on a day-to-day basis and how he's enjoying his hobbies and whether he's being able to do the best he can at the snooker table or not?
Or
It's got to be
dentists.
it's got
Dentists,
to,
that's another one. Dentists.
But
Dentists.
dentist,
Mm,
yeah.
mm,
So that I just want to put that out first because some of the tests we do, I feel are the tests, and people are ticking off the test. Oh, yes, convergence is fine. And I always say, fine for what?
mm,
Fine for what? And I'll put something else out there, which is relevant to what we're saying now about testing, is what we say he doesn't have convergence insufficiency, let's say. So I say the the follow-on from saying he doesn't have convergence insufficiency must be he's convergence sufficient. And then I say sufficient for what?
mm.
Why am I doing these tests? I'm doing these tests really to find out if he is convergence sufficient for every aspect of his life. So I need to understand what are the vergence demands of all those things. And that's, of course, going to govern how I'm looking at him when I'm doing the tests.
Mm.
So, of course, the first test I'm going to do, um, I am going to do, of course, a near point of convergence test.
Just show us how to
Um,
do that. The best way to do it. What target you use, or tell us. Well,
Well, the target, the one which has most research really, and if you look at the papers from what if if people listening to this, if you really want to look at a very wonderful review, I would recommend the paper by Dr. Jeffrey Cooper from SUNY, who's been teaching there for about 47 years. Outstanding paper, Jeffrey Cooper, and another wonderful paper by Liat Gantz. And what you will see there is that the definition of convergence insufficiency is there's so much disagreement on that, of course,
mm,
depending on what tools you're using. And it still comes back down, are we answering the real question of levels of comfort, subjective levels of comfort? So in the convergence insufficiency treatment trial, the standard there was using a pen light, red-green glasses, doing the test 3 times because Shaman has shown that for people who have convergence insufficiency, when the test is repeated, you'll see a greater degradation in their performance than for someone who doesn't have convergence insufficiency. So
across every
repeating
trial.
the test
Mm.
again and again is going to reveal the difficulty.
But
So
why would
I'm
they?
going to,
Sorry, why did they use this is maybe my ignorance, but why would they use a light, which is a non-accommodative target, to test something which in natural world requires accommodation as well? Or
that's a great test. And I would say a good answer to that is when we read, we will always accommodate minimally for identification.
mm,
Right? I will never, if I'm reading an easy text and I can infer what the next word is based on my language processing, I'm hardly going to examine every single aspect of that letter in great depth and get it accommodate fully. I'm going to be working with a lag of accommodation. And then I may come to some unfamiliar word and I may accommodate more.
wow.
Now,
Mm.
if there is a strong relationship between accommodation and convergence, then you will have this situation whereas the accommodation changes, the vergence is changing.
Hmm.
And so I certainly would be in a school of thought that it's very important for me to see how convergence behaves independently of
Okay. So you
accommodation.
want to separate it out and measure it on its own. Okay, fine. Yeah.
And in treatment, we are fastidious about that. In
Mm.
treatment, we're fastidious about developing what we call ranges of freedom so that accommodation can switch as is necessary, but vergence will remain stable on the page. And
Okay. So just to clarify, you're actually encouraging a kind of partial dissociation,
the potential
potential to
for
switch it on and off as okay, according to
and
demands.
but
Okay.
each absolutely,
Okay, so
absolutely.
red green glasses and a light target, and what's the instruction you're telling the patient?
Well, you're asking the patient to tell you that 3 times, and it's on the coming up. Tell me if it goes, if they see 2 lights,
Hmm. So what do
right?
they see initially when they've got the red and green together? What does it look like to them?
Well, it's called luster. So they'll describe it as red, green, some sort
Okay.
of luster.
And
And
then
you, yeah, and the fact that they're 2 different wavelengths makes it more difficult than looking at a single target as well.
Mm.
Fusion's slightly different. And you're looking for the break point there outside of 10 centimeters. So if it's outside of 10 centimeters,
The 10
then
centimeters being the no, the
on
normal.
that test, on
Oh,
that test after the third one. Now, typically I will use a fixation stick in my clinic. I mean, that's a test which has, of course, come later in my career. So making the shift not always easy. And I'm very interested in what the patient looks like when I do the near point and convergence. I'm looking at their face.
So using a
And
stick there, so like that sort of stick, not
yeah,
not to stick with a letter on or something. Yeah.
yeah, I am using the stick.
Okay.
And I'm looking to look at what their face looks like. I mean, at the minute, if I see the frowning, I don't care if they get to 5 or 3 centimeters to their nose.
Ah, okay.
No, no, no. I want vision to be as easy as breathing. You know, people can get oxygen from out in, and they can hopefully do that easily.
So
God
you're
willing.
measuring the near point of easy convergence or comfortable convergence.
Yes,
Okay, right.
because that is the one which can affect their choice making. Now, while it's true there are many reasons why someone might not choose to pick up a book, when they're in my realm, I feel my obligation is to find out if there is a visual part to that story.
Hmm.
Is there a visual part? I mean, no one else is going to do that. So they're in my chair. So if they are frowning at 30 centimeters, which is about where they hold a book, I that gives me permission to ask. Now, people are in different, it happens to be in my practice, people are coming to find out they already sort of primed because someone referred them to the practice because they were struggling with reading. They know why they're coming. But I think for a general practice optometrist, a lot of people are not doing these tests because they feel if I were to do the test, which I learned in university, what would I then do if they fail? And one of the things I like to talk about is permission to ask. It gives you permission to ask. Meaning, if you do that test and someone at 30 centimeters is uncomfortable, it gives you permission to ask about their workday. How are you feeling in front of the computer? You can give them instructions about taking breaks. Maybe you can provide them with a pair of glasses to look at the screen. And so you don't have to be in a treatment mode in order to be able to help your patient.
Hmm.
If you don't do these tests and don't see they're struggling to converge, or that it's not uncomfortable at 30 centimeters, then you won't even have the conversation. And it's us, the eye care providers, practitioners, who are the only people who these people who are challenged can have a conversation with. And they'll say, wow, I always thought it was because of. I
Mm.
thought I had ADHD. I thought, I'll give you a million reasons why. Oh, I love reading slowly, they'll say. You say, well, what happens if you could read 3 times the speed and have the same level of comprehension? Would you not enjoy that too? Say, well, yeah. Most people would say, yes, I would.
Mm.
And so the near point of comfort is my first measurement, and it's on my
Mm.
record card. The first place they report discomfort, first point of interference, it's
Mm.
on their record card. And then I'm looking to see what they break at, and I also want to see what their recovery is, and I'm going to look at their face. Now, for me, it's then not a pass fail.
Mm.
I'll be looking to the Pickwell test is the next one I'll do.
Tell us
Pickwell
about that.
test. That's looking um, that's looking far away and then converging. So I'm looking at 6 meters, and then I'm holding this at 10 centimeters, and I'm asking them to come to it.
So
And
it's
that's what we do in life, right? What we
yeah.
do in life is we're generally not looking at objects moving slowly towards us, but we are looking from object to object. So we're always making these sorts of movements as we move through space. It's always a jump convergence of maybe a jump divergence, but
Mm.
it's not things coming towards us. And in that context, I think, Nadim, it's so important to reiterate again that words are not coming towards us when we're looking at the
Mm.
page. So
Mm.
if you think that passing this test tells us we're convergence sufficient for reading, you're looking at like at apples and oranges. I mean, neurologically, this is so stimulating. Something's coming towards me. Of course, you're going to look at what's happening. If
I
you
th
fail the test, however,
mm.
it's critically important.
Mm.
It's like testing someone to climbing the stairs to see if they can climb the Himalayan mountains. Now, if you manage to climb the stairs, you would be irresponsible to say, well, you can climb the Himalayan mountains. But if you surely fail at climbing the stairs, you surely will not be able to climb the Himalayan mountains.
Okay,
So it's
so
so important the tests we do
mm.
are appropriate for the task. And I
Okay.
think that's where it's not quite always happening. I've got more. more tests I do. But yeah, Amber,
Yeah, no, we'll
I
come
like
back
your
to them.
question.
But so these kind of moving in tests, the slow moving in test is a more basic and they should do well, should do better on it. The jump test you talked, the Piquel test, a more challenging test. How are you assessing the response of that? Just again, facial expression, difficulty. And you
Yeah,
said 10 centimeters, you're not measuring a distance on that, you're just commenting on.
no, it's 10 centimeters.
Hmm,
And when I do that test, um, I'm looking for symmetry of movement.
okay.
That really reveals. See, the near point of convergence test, one of the eyes will may or may not go out. You may have effort, or they may break, as you say. The Pickwell test, David Pickwell, um, that test is going to reveal those situations.
Mm,
Boom, 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 boom. Now, no one goes to the doctor and says, I can write with my right hand, but not with my left hand.
mm,
But I think asymmetry is part of being human.
mm,
And that asymmetry, I wouldn't call it a problem. I mean, anything where you're failing visually to meet the visual demands of reading, I refuse to call it a problem because the visual demands of reading themselves are so unnatural
mm,
that I see so many people who can meet all the visual demands of their life, but they're nevertheless struggling to meet the visual demands of reading, which are so unnatural. And I think it's like someone who's swimming, wants to be in the swimming team, but they're just not good enough. A bit of coaching and working on their motor skills will help them
mm.
do that.
Okay.
And so the Pickwell, what I'm looking for when I do the Pickwell, that
Ace.
again, can they do it? I can't. Kids keep copying off the board, right?
Mm,
Copying off the boards. That's much more like copying off the board than doing the near point of convergence test.
mm,
But what I'm also looking for is that asymmetry,
mm.
because when there's a lot of asymmetry, so as they're moving across the page, it would be fair enough to say that one eye is lagging till they get from one word to the other. That's going to slow the whole story down.
Okay, so that's test number two. Are there any others?
Yes,
Go
there
for it.
are. I like doing the Vergence facility test,
Mm.
which it does come up in, it certainly comes up in Gantz's paper, and that's with a 12 base out prism
Just hold it
and
up for us there, right? Yeah, we go a bit higher. Yeah,
there you
so
go,
12 base out prism. Okay,
and a 3 base in prism.
right.
And I can't quite remember what the norm is right now, but you're looking at a near target, and
Okay, so unilateral vergence or divergence. Is that what you're trying to do?
yeah, well, the response is binocular.
Oh, the other eye moves as well?
Well, when they converge,
Oh,
the
yeah, it
eyes,
does. Yeah, it does. Yeah.
yeah.
Mm.
Yeah, there's always monocular input, binocular output in most situations, unless you're in this
Hang on. So,
unnatural situation.
so is that going to be a test for ocular dominance then, or will because won't it be the dominant eye that triggers it, or both eyes will elicit a similar response?
Um, both eyes will not. Again, one eye they may manage more than the other,
Uh-huh.
depending where you put it. But the point is for me uh, is again, it's starting to mimic visual demands of refixation.
Okay, just show us that again. I haven't seen that before. Maybe some of my colleagues haven't seen it either. So just do it on yourself. Yeah, please.
Yeah. So, well, I
Okay,
look at
yeah,
the camera here. Can you see
yeah,
me?
yeah.
So divergence, convergence, divergence, convergence, divergence, convergence,
And what happens to
divergence.
somebody with problems? What do you see?
So you see, sometimes when you do that, there's no response at all, and they can't even see the second image. And
Okay.
they're suppressing that second image. And at that point, I'll put it vertically, and they'll see it, see it, see it, see it, see it. Oh, now I can see the two. I can see you actually twice
Okay,
on
so
my screen.
you train them to see it. Okay, yeah.
And yeah, and then we do the test.
Mm,
And can you bring the two images together?
mm,
Okay, so nothing's moving towards me. I'm looking at a stable target, so it's now more mimicking a word,
mm.
and I'm seeing how quickly can you automatically resolve
A
the
disparity.
diplopia, respond. It's my stress testing, right? Like you
Mm.
take your car or
Yeah.
your heart. I'm not with them 8 hours a day, so I need to do some tests which push them to a limit and see how quickly can the system respond, especially when they're looking at targets which themselves are so low stimulus for convergence from a neurobiological perspective.
Yeah.
And I think, and then we've got, well, then there's going to cover test and fixation disparity.
Yep. I can see
Um,
that. So which one do you use? So which is this is that a fixation disparity test? Which one are you using?
yeah, so that's the fixation disparity test. You've got the
Which one
uh,
is this?
mallet.
So that is the mallet. Okay, fine. Right.
There it is.
Ah, yeah.
Mallet.
Okay, fine. Yes, it says mallet.
Yeah, Mallet was actually a lecturer of mine, I'm happy to say.
Yeah.
These people inspired me. You know, we all stand on on the shoulders of others, and I thankfully stand on the shoulders of so many people. I've been
A lot of
privileged
people
to.
stand on mallet's shoulders, I have to say.
Ron
Okay.
Mallet, character.
This is while we're on this, I was going to have maybe we'll have a separate topic on fixation disparity. We won't get too far into that today because that's another whole topic. Okay, so but you say it's crucial for convergence in particular, as opposed to just binocular control.
Well, again, you know, Mallet made sure there's text around his target. He wanted to mimic what's going on. Right? So my eye, I'm not seeing diplopic, but there are the nonius lines. See, I'll just light them up for you there on
Mm,
those nonius lines.
mm,
Um, if there's going to be slip, they tell me directly what's happening, the stability of the two eyes, whilst I'm trying to align them on an essentially non-stimulating task for biological stereo alignments. I mean, I'm
mm,
aligning them to avoid diplopia. The purpose of single fusional vision is not to avoid diplopia, it's to know where things are in space so that I can respond to them, as I mentioned previously. But in the reading situation, the whole thing is just to try and avoid diplopia for no real gain. Of course, if I read with one eye, it's no less of a meaningful experience.
mm.
Not
Okay.
compromised.
So, any other tests for convergence specifically, or are we done on the convergence? I mean, that was enough, but are there, that would give you a pretty comprehensive, well, a much more comprehensive view of convergence than just saying, how far can you see that? And
It
so,
will. And,
right.
yeah, there's also the convergence insufficiency symptom survey. And that's bringing the
Ah,
subjective experience, and that's very well researched. And that's bringing the subjective experience into not just looking at their face, but asking specific questions which relate to. Uh, and there's a point system there as well, which you can
okay.
look at.
So
Yeah.
convergence, we'll move on now to abnormalities then. So convergence insufficiency, is that well, I think that's pretty obvious. It's going to be a spectrum, but is it an umbrella term for lots of different things, or is it just a kind of description of an underlying problem with the system?
Well, Nadim, I think this is the thing when you read the papers and you see the huge spectrum of definitions of convergence insufficiency, it shows, to my mind, the tremendous lack of clarity. We're not talking about what we're really testing,
Mm,
which is, I'm coming back to it, is the patient convergence sufficient? So convergence, right? They don't have convergence insufficiency. We are implying they are convergence sufficient. So if we want to, what's the advantage for us as professionals? The only advantage is that we can talk to each other if we say, oh, it's like the amblyopia, right? They have to have two lines worse to say they're amblyopic on the Snellen chart. Well, what happens if they have one line worse? What? So they don't have amblyopia? It's not. It's what do we call it? So we've evolved as a group in a certain way, so we can meet at conferences and talk and share information and publish. And all of this is important, and it would be next to impossible if we couldn't agree on certain definitions. However, you and me know that when we hang on to those definitions, as you had a sort of lovely post about the pilot the other day, when we hang on to these definitions, they don't always transfer into reality. And by me saying if they're not convergence insufficient, then they're convergence sufficient, that says, wow, I didn't think about that. So I need to know if he is convergence insufficient. So I think that the word convergence insufficiency has meaning. If we could agree on a definition, I think the convergence insufficiency treatment trial, and they're using the red green glasses, they've tried to nail it. Like, this is convergence sufficient. This isn't, together with the questionnaire.
mm,
However, there'll still be, of course, exceptions, right? Someone could be suffering greatly in
mm,
one area on the convergence insufficiency symptom survey, But because he hasn't answered that he's suffering in many areas, uh, he has not failed. He's passed, but he's suffering every day. So what? I can't treat it because he doesn't fit into the
Yeah,
box.
yeah,
So I think the answer is it's hard if you really think honestly and practically and clinically. You can't put it into a box if we're saying our job is to relate to the visual needs of the person
no, I agree.
sitting in the chair in front of me. I
Okay,
hope
so
that's a satisfactory answer.
yeah, totally, and I agree with you. So you have a patient who has symptoms which you think could be related to convergence, insufficiency, or problems. You've done your tests which confirm that, on testing, they do have problems with the convergent system. Um, what are we into now? To tell us about a little bit about how you would manage these patients.
Okay. So the first thing I would do, and I think it comes from trying, first of all, the first point of management is informing the patient. That's the beginning. And the reason I say that is because um, there was a wonderful optometrist called Robert Kraskin who wrote in the 60s the importance of a patient making a choice. So I'm going to say, um, obviously the glasses, I'm not going to go into that whole thing of prescribing the glasses, whether we're using prisms with fixation disparity or not. Um,
But basically, just
that's a
just to
different
just
topic. Let's say,
but just to go on to that, I think that's really important though. Everything else has to be optimized in terms of refraction, in terms of fixation disparity, all of that before we start. You can't just address one issue. Is that what you're pointing out there?
I am saying that, and I often feel that glasses provide the ambience.
Hmm.
So I lecture a lot, I have different models in my head so people can understand. And I say that glasses are like having the perfect piano stool. Sometimes, if you don't have the perfect piano stool and you're reaching up to play, you're reaching down to play, and then someone gives you the perfect piano stool, it's a game changer. And you don't need more than that
Mm.
because your motor skills are actually quite equivalent between the two hands. However, if in one hand you have great manual dexterity and the other hand is pretty pathetic, someone's saying, well, why don't you just get the right piano stool? It's a bit cruel to do that to not have the discussion. You know what? You need the right piano stool, but you might need some work on the motor aspects so that you can play both hands together,
Mm.
if that's what you're trying to do. And I'll take it one step further than that, just to let you know what my goals are for my patients when we think about reading, because we're actually moving two cameras simultaneously. I can think of no other human activity where motorically you need both sides of your body to be in exactly the same place at exactly the same time. There's no situation where we play a piano key and the quality of the sound emanating from the piano is dependent on the simultaneous precision of us pressing on the one note with both hands.
Mm.
Doesn't exist. But the quality of reading, my two eyes are not simultaneously moving. You do not have to be an ophthalmologist, optometrist, or anyone to understand. Yeah, I get it. I get it. I get it. May not be the end of the world, but it's going to interfere. If that's a situation, that's a different story to that being the situation.
Mm.
So the first thing I want to try and do is to describe to my patients what I found, and as you say, give the right glasses, give them the right ambience, and that can be enough sometimes, right? Um, but if I can offer them to perform better, and I'll describe how I feel I can help them. So some of the tests I do are separating between language problems and visual challenges.
Hmm.
That's very important, right? If someone's reading slowly, you need to know, is it merely because they're taking a long time to move their eyes across the page? Or no, they're looking at a word and it's taking them too long to say it, even though they know what that word is. And one of the tests we use for that is the developmental eye movement test, which is wonderful because it has a language aspect to it, where a person is reading 80 numbers and you're saying, do they read those 80 numbers uh, at an age appropriate level? Now they know the numbers. You make sure of that beforehand. So if they're saying 7, 1, 6, 10, 4, and they're 13 years old, they have a language-based learning difficulty. And that helps you say to the patient that even if I can help them visually, they may still read slowly. Now,
Are you picking
uh,
that up in adults as well for the first time?
I'm sorry.
Are you picking that sort of problem up in adults
Oh,
as well for the first time?
that is so painful. Yeah, that is very hard. And it's hard all round because it's hard because they look back at their life. We we look at two different things. One is, which is part of my effort to try and have these conversations. And thank you, Nadeem, for having me on, because reading is not a niche activity. And it's one of the hardest things we do as human beings with our visual system. So my feeling is, here's the one. There's another thousands out there. We need more of us doing this. Binocular vision is not a niche or a special interest activity. And of course, for them, when they understand that in 16 weeks, everything's going to look entirely different for them, and they've been through so many people, uh, the change can be very profound, very profound. I have a patient, he came to me, and his goal was, his teacher came to me 6 months ago and asked me, do I remember a certain patient who was with me in 2014? At 17 years old, his goal was one day he'll read a story to his children. He said to me, you should know this patient. He came to me in 2014. He was actually with me for 35 weeks. We worked on visual perception training as well. It was one of the longer treatments. Most treatments are 16 weeks, so that's it, 16 to 20 weeks. Anyway, today he's in his postdoc in psychology, and his goal is to set up a multidisciplinary center for children with learning difficulties. And I phoned him because, okay, thank you, but is it true? Yeah, I was on the phone with him for an hour. So yeah, we do get adults. Sometimes the parents are sitting in there with their child and say, you know what, this is me. So I'm coming in as well. So yes, we do. Of course, we get adults, and it's the first moment they see it. And of course, all I say is I'm just checking vision. I'm just checking vision. That's it. I'm checking everything you're trying to do every moment of your life so that you can live. I'm the guy who's going to see how well you do it if there's something interfering. And I'm coming back to that choice thing. That's why I have to explain, because they have to feel free enough to walk out my door or choose to come for treatment. 35 years, I will not tell anyone, you have to do this, because you can live till you're 120 the way you want to live. That's not my business. My business is, if you decide to come to my office, I want to deliver according to what I've expected, what your expectation is that I've shared with you.
Okay.
So the treatment will be this,
Yeah.
coming back to what you're saying. Yeah. So if I've seen anomalies, and I'm not only testing convergence, of course, I'm testing monocular skills as well, accommodation skills, checking all the things we do. And that's going to decide where and how I'm starting my optometric vision therapy. But the therapy, a big part of it, is to equalize the monocular skills, both in the oculomotor and in the accommodation. And what I can tell you, Nadeem, over all these years, is I see everyone every 7 weeks personally, and I will always check their binocular function on positive and fusional reserves. I haven't mentioned that. Sorry, that's another test I do. Positive and negative fusional reserves.
So tell us how you do that, just briefly.
Well, I use the binocular visual assessment program. It's an RDS, red blue glasses, and you get a break recovery and a break recovery. And of course, you're looking at 35 centimeters, so your accommodation is fixed. So you're looking at vergence independent of accommodation. And what I want to say is after 7 weeks, most of my patients have not done anything binocular, but by merely equating the monocular skills of those two eyes, you start to see often very significant changes in binocular function. And that, someone like you, a neuro-ophthalmologist, that probably makes sense.
It is surprising though. I mean, I still think it's quite amazing, even though it makes sense. I think it is amazing. The natural thing would to think you would have to practice what you're actually doing, but it's a bit like training in the gym versus running on the track, isn't it? So
no, but Nadeem, if one eye is lagging behind,
exactly, yeah.
why do you think they're merely forcing them? And the convergence insufficiency treatment trial put to rest any assumption that doing pencil push-ups can serve as a long-term cure for convergence insufficiency. And I think the answer lies in what I just explained, that the convergence insufficiency, I feel, is a manifestation of the asymmetrical, perhaps proprioceptive situation based on, I'm taking from Richard Bruenech, who spoke to us about intermittent exotropia. And I imagine it's a scale, like you said, a sliding scale. And perhaps that eye, which goes out when we do, why is it that eye? is perhaps the whole proprioceptive feedback mechanism
Mm.
is not working as well in that eye as the other eye, even though the neurological innervation is the same. There's something motorically, and Bruiner talks about doing exercise, stimulating work to improve. And in clinic, that's what we see, as I've tried to show on the videos, which I show up sometimes on LinkedIn.
I think we're just going to repeat that. That's a really important point. So you're saying that convergence insufficiency is very often, if not always, but very often due to asymmetry between the oculomotor abilities of each eye, and therefore getting the weaker one up to scratch is going to be what solves the problem. Yes, is
Yeah,
that
the word weaker is something which I'll
you don't like
kick
weaker?
back a bit on. I don't like that word so much because the eyes weigh 9 grams. So I
Mm.
don't think it's about strength. I
Mm.
think it's much more about the neurological connection, the
Sure. Yeah.
proprioceptive feedback from the
Yeah.
myotendinous cylinders, not about. And I say to my patients when we're doing vision therapy, and it's relating to what you're saying right now, which is I say it is not a gym. The mantra in my office is easy as breathing. Easy as breathing. I want to see the Mozart. I want to see the orchestra. I want to see the symphony of ease and grace. Those are the words we use.
Mm.
Ease and grace. Because doing seeing takes up so much resources that we close our eyes when we want to smell or think or listen. We never do this to see better, right?
Mm. Mm.
So so I want to, when I'm learning, I need the resources to do that other thing. I mean, who in their right minds would use their eyes to read if they want to learn?
Mm.
No one.
Mm.
We that's using a lot of energy just to gather the information, process it, that I can then use cognitive function, executive function, etc., all the other things, right? So if I can reduce what I call vision tax, that's what I think is the game changer for the experience of the patient. I mean,
Mm.
that's what they come back and tell. They start telling you all these other things which have changed or they're noticing, etc.,
Mm.
etc.
Mm.
And I think that's why when you give more resources available for higher level processes by taking the effort out of seeing, that's when things really start to change. Yeah, in a bigger sense.
Mm. Okay, two more questions. So, the treatments you give, you said they're normally around 16 to 20 weeks. Are the results of those sustained long term, or do they need to come back and have further?
Great question. You ask great questions, Nadim. So I say to my patients, if it's not the only cases where the maintenance will be uh, required would be when there's strabismus.
Mm.
So if I have an intermittent exotrope, um, basically those would be the greater cases. I have a patient with an esotrope, which I'm just writing a paper now. Actually, he's 3 years or 3 years post treatment. He was a 35 esotrope, and he did no maintenance pretty much, and he's still stable where he was when he finished. Um, so because we're doing SIGGing all the time, when you develop the motor skills, so they maintain and they just get better and better, you
Mm.
need to be very fastidious about visual hygiene and having the right glasses. So if after doing my work, you then go back to your lousy habits of looking at the screen for 8 hours a day and not taking a break, you may well come back with exactly the same presentation. I haven't spoken about accommodation and convergence. Of course, it's
We'll
it's
talk.
it's very
I think
important.
we'll
And
we'll have another chat on accommodation.
yeah, but I just want to say the accommodation, when we said convergence can
Yeah.
sometimes be terrible, just because if the accommodation is lousy,
Yeah.
then that's not necessarily to do with how the two eyes are working. You may have poor convergence. So I forgot what you
No,
I
just
forgot what
how. So you're basically saying that as long as they don't go back to the old habits and they keep up good visual hygiene with the right glasses, they may not need maintenance treatment later.
I would say 99% don't need. And the ones who come back, when I look at the positive and negative fusion results, so many of them have improved even more.
Mhm. Mm.
And the motor skills, for sure, if they start engaging in reading, then the act is like playing the piano, right? The act of the engagement in the reading will refine
Becomes the
the
maintenance.
quality.
Yeah.
Yeah, it'll
Okay.
develop more and more. Yeah.
Okay. Final question, just because of time. Let's go the other way when people over-converge, convergence spasm, for example, or other degrees of over-convergence. Do you see that much? How do you approach that?
Okay, so you're going to be looking, first of all, of course, you see it. Well, let's call it, if I say esophoria, is that okay? Or you want me to talk about something else?
So yeah, so what I'm talking about here are those people who kind of, well, this is what I want to explore really, because when we talk about convergent spasm, what we're really talking about is spasm of the near reflex. So they get a convergence, they get accommodation, hyper accommodation with myopic shift and small pupils. They often have quite uncomfortable for them. They can't abduct during these episodes. That's what I'm talking about. But I mean, I'm interested in seeing whether there are other conditions of over accommodation, sorry, of over convergence, which are less than that.
Well, you say over-accommodation, and then excuse me, but the over-accommodation is often the driving force
Yeah.
for the conversion, especially if there's a high ACA. So
Mm,
my first point of call is, what are you doing in your life? People will phone me up and they'll say, I'm about to give up my job, I can't work anymore, etc., etc. I'm seeing double when I look on my windscreen, I'm seeing double when I look far away. I say, well, look, let's just start taking breaks.
mm,
And if you feel uncomfortable after 5 minutes, take a break. After 5 minutes, look away 20 seconds. You know, people talk about 20, 20, 20. Sometimes people need more than that.
mm,
I will call you in 6 weeks, and I put it in my diary. I will call you in 6 weeks. We'll have a conversation. Can I tell you the number of people who say, "Thank you," you know, that sorted that out,
mm.
right? So we are living, you know, we're built to look far and to occasionally look near, right?
Yes.
Our accommodative system is a smooth muscle. And how long do I need to identify anything in real life for, right? Like you look at the thing you're eating or catching, and then you've identified it. It's not changing every 150 milliseconds.
Mm,
The act of constant identification is another proof how socially, how biologically unacceptable reading is, because there's nothing in real life which comes close in terms of the need to sustain accommodation to keep identifying. You're with me there,
yeah,
Nadim,
totally.
yes?
Yeah.
So it's very, again, I just want
It's
our
unphysiological.
audience,
Mm,
our audience to understand how high demand that we all do it. People seem to be stuck in this idea that, well, everyone reads. Well, the ones who can read do, some don't do so well, and some people are out of the picture.
mm.
And so screens as well. Some say I hate computer screens. You know, we don't. So
Phone,
yes,
not to
first
mention
first
phone.
point of
Yeah.
first point of call is yeah, what are you doing? And let's take the breaks. After that, the right glasses, if I can. But that taking the breaks of visual hygiene, it changes a lot. It's not a little thing just because it sounds easy. It's changing everything for the patient during their day. Instead of never looking away, hardly ever for 8 hours, they're now looking away every time they feel uncomfortable. Things start to heal and rebalance, right? Thank God, you know, our eyes work, things can heal, things. If you take the stress away, the body will heal.
Mm,
And that's so important rather than jumping in with treatment or jumping in with that. That's the first thing I want to do is clear the decks. Let me clear the decks. If you and then I'll see you again, but I don't want to see you for 6 weeks until you clear the decks.
mm,
Then I see what they need. They may need, you know, check them on duochrome while they look at a computer screen at their working distance. Give them the right glasses for that. And that can also be a game changer. And then I'll look at the other things you manage. I may do some vision therapy using minus and plus lenses, plus lenses. So there's a wonderful activity where we want to try and get for someone to be able to look through a +5 lens. Right? You imagine you're releasing your accommodation by 5 diopters. Take the lens away, the image should stay blurred, which
mm,
means you're maintaining the relaxed state. How do you know when you put the lens back in, it's clear instantaneously? Now, that can take weeks of work, but it's giving biofeedback through the visual system. So instead of someone saying, well, just relax, with optometric vision therapy, you can create the opportunities to learn, understand, or sense what it looks like when I am relaxed.
mm,
Because you can present targets which can only be seen when you're in the relaxed or divergent state. So targets which can only be seen when you relax accommodation, or targets which can only be seen when you get into a divergent posture. And so this brings the patient the ability to move in that direction.
mm.
And might combine that with breathing, relaxation, building up the parasympathetic response instead of the sympathetic response, those sort of things.
Robert, we're at the end of our time. I think it's been a fascinating discussion for me. I've learned a lot of things today. I'm sure people listening will also have learned a lot. And I look forward to getting you back another time to talk about several other topics, which I know you're very interested in as well.
It's been a pleasure, Nadim. I really want to thank you for the opportunity and I hope it adds goodness to the world.
Thank
Thank
you
you.
very much for your time today.